Okay, hi, welcome, and thank you everybody for attending this webinar, Starts at Home, Enhancing Residents' Wellbeing and Relieving Pressure on the NHS. My name's Susanna Young. I'm a policy officer here at the National Housing Federation. I've got a couple of housekeeping comments just before we get started. So to let you know that the webinar is being recorded and the recording will be available next week. There are also a number of ways you can engage with the webinar today. You can use the chat tool to speak to each other. Make sure that it's set to all panelists and attendees so everyone can see what you're writing, and you can ask questions during the webinar using the Q&A tool at the bottom of your screen. You can also upvote other people's questions and comment on them. We'll take as many questions as we can, and please do submit questions throughout the session and then we'll come to them at the end. So about the webinar, many of you will be aware of Starts at Home Day. It's a day when we celebrate supported housing and the positive impact it makes on thousands of people's lives. We know that during the coronavirus pandemic, supported housing providers have worked to ensure their residents are safe and healthy in their homes, and they've worked to relieve pressure on the NHS during this critical time. So ahead of this Starts at Home Day, which is the 3rd of September, we're running this webinar to explore how supported housing providers stepped up to meet pressing demand and how they can continue to support their residents' wellbeing while also working with the NHS and social care. Our speakers will share how supported housing providers have and can work with health and social care and the role supported housing has to play in positive health outcomes. We'll hear from Angelina Morgan, who's Director of Mental Health at Look Ahead Care and Support, Emma Cookson, who is Senior Policy and Public Affairs Officer at St Mungo's, and Charlie Norman, Group Chief Executive at Moscare St Vincent's Housing Group. Okay, that's enough from me. I'd like to pass on to Angelina for the first presentation. Thank you.
Thanks very much, Susanna. So I'm Angelina Morgan, Director for Mental Health in Look Ahead. Look Ahead is a housing association. We've been in operation for nearly 50 years now. We started off working in homelessness and have since expanded into 4 core client groups. So that's young people, mental health, of course, learning disabilities and homelessness. We mainly operate across London and the South East, and we deliver a range of services. So crisis prevention, community rehabilitation, forensic step down, complex care, hospital discharge, which I'm going to talk a bit about in a moment, and also CQC registered services. In terms of our partnerships with health and local authorities, these are largely a collaboration based on a mutual and invested interest in supporting people to achieve their best health and social outcomes. We also operate within a number of different commissioning arrangements. So in our community rehabilitation services and our crisis houses, we generally tend to subcontract the health trust to deliver clinical input into those services. And if, for example, at our community rehabilitation service, we subcontract the health trust to deliver psychological input, occupational therapy, consultancy, and also there's a nurse available as well. And the clinical team there come in on a weekly basis to meet with the support team for supervision and also casework formulation. And I guess that's a very good example of integrated working on a micro level. We talk about integrated models of care, integrated working, and I guess there's different levels to that, but at a micro level, I think that's a very good example of how it can work really well. In terms of our approach to establishing and maintaining long-term relationships with our partners, these, they have to be built on trust and cooperation. We work in a coordinated and joined up way, and that's generally how we work across all our mental health services in Look Ahead. And this is often triangulated with housing. We want to provide a holistic support that's inclusive of health, social care, and of course, meeting the ongoing housing needs of the people that we serve in their communities. We are a housing association, as I said earlier. We have a number of properties across London and the South East. We also, we operate out of other landlords' properties, and other landlords and providers operate out of our properties. So partnerships with landlords is really important. Other housing associations, health trust, property services, private landlords, and of course local authority housing departments as well. During the pandemic, like St Mungo's, we provided support into hotels, and this obviously aligned with the government's initiative to support rough sleepers off of the streets and into some form of safe accommodation. We also delivered hospital discharge services across a couple of health trusts, so working with Camden and Islington and Barnet, Enfield and Haringey. As well as hospital discharge services, we set up community specialist floating support services. Of those services that we set up during the pandemic, the hospital discharge service has been a real success in Camden and Islington. We've seen some really positive results from that. We've seen a reduction in readmission rates down from 10% to 3%. And also shortened length of stay from an average of 50 days down to 42. So actually they're really positive outcomes, and that contract has since been extended. The medication floating support service, also commissioned by Camden and Islington, is to support people at the other end. So after they've been discharged from hospital, we'll pick them up in the community and support them, specifically with regard to their medication, but also if they have any other concerns, we'll support them with that also. And the aim of that service is to provide or to support people to avoid readmission into hospital. Towards the back end of last year, Barnet, Enfield and Haringey approached Look Ahead to help them with a problem. They needed to empty their bed spaces across all their wards in the hospital, including their mental health wards, to provide bed spaces for COVID patients. And so together, working in partnership with BEH, we were able to set up and mobilise a floating support service within 48 hours, and this was just before Christmas. To support those people in order for them to be discharged from hospital. And again, that service was really successful and produced some very good outcomes, and that was extended beyond the end date of that contract. So that was really positive. So I guess in terms of last year, we supported around 1,500 people across the mental health pathways that we operate within. And as I said earlier, we are increasingly working with NHS trusts to deliver specialist integrated services. With regard to the hospital discharge services, we have specialist workers that work in ward with the access and flow team. So they're fully integrated into the ward. They've got access to RIO or the databases that the health trust use for patient information. Their main role is to support the patients in ward, particularly around housing issues. That seems to be the biggest area of support. To overcome any barriers, sort out any benefits, to enable that person to be discharged from hospital safely and back home. And of course, it also avoids delay to discharge. So that's a really useful thing. We, in 2019, Look Ahead commissioned a consultancy firm called Europe Economics to carry out some analysis into the cost savings and other benefits resulting from integrated mental health models. And there were a couple of interesting things that came out of this report, and it is available for you to just have a look at if you've got time. But a couple of headlines that I'd like to mention now. They found that supported housing can prevent readmission and produce positive outcomes for the people that use those services. And those outcomes are largely around gaining independence and access to employment, training and education. And they also found that based on their analysis of 3 core models within Look Ahead, so that's crisis care, community rehabilitation and forensic step down, those 3 models combined produced a saving of £5 million a year compared to hospital-based mental health care. So that's quite a big figure. In addition to that, Europe Economics predict that by scaling up, these integrated models could generate nearly £1 billion of savings to the NHS. So it makes for interesting reading, and I think there's clear evidence there in that report that there are benefits not only to the customer in terms of working in an integrated way, but obviously to the NHS and central government, local government departments. I welcome the recent white paper, government's recent white paper on integrated ways of working, and of course, also following on from that, the integrated care systems that we're seeing come together across the country. You know, we were working in an integrated way prior to the pandemic, and we were also delivering integrated models of care prior to the pandemic. But I think what we saw last year was an exponential increase in working in this way. And I think what it demonstrates last year for me is that, you know, it really demonstrated health, social care and housing at its best. And I'm really keen to see that way of working continue, and also, you know, to be establishing new partnerships across the sector. I'm now going to hand over to Emma Cook from St Mungo's.
Hi, thanks Angelina. That was really interesting, and I'm looking forward to reading your report. So, hi everyone, I'm Emma Cookson. I'm the Senior Policy and Public Affairs Officer at St Mungo's. I'm going to be looking at, in relation to health, what happened over the pandemic for people sleeping rough. Next slide, please. So I've got my snazzy comms. St Mungo's in a nutshell. So we're a homelessness charity which works with people at every step of their recovery from homelessness. We were at the forefront of the response, supporting people who were rough sleeping or at risk of rough sleeping throughout the pandemic. So I think we supported more than 4,000 people in the emergency hotels, which were provided as part of the Everyone In initiative. And according to government, the Everyone In initiative led to more than 37,000 people being moved into safe emergency accommodation. Next slide, please. So we are also, as St Mungo's, we're also supporting the Kerslake Commission, so we're secretariat for that. Kerslake Commission is an independent commission led by Lord Bob Kerslake to examine the learnings from the emergency response to rough sleeping during the pandemic. And we're really hoping that the Commission will drive that long-term change that's needed, so that Everyone In isn't just sort of a footnote of here's a period that went really well, but really produces a long-term legacy. And we want to really embed the positives that we learned from Everyone In. So we published an interim report in July, and the final report's going to be coming out on September the 23rd. And I think one of the main lessons that we learned doing this report was that during Everyone In, as Angelina mentioned, partnership working was really spurred on, and generally it worked really well. And we want to look at ways that we can really embed that, so that it's not just a one-hit wonder over this year where people came together, but we have news, like the changes really put into the system. Next slide, please. So crucially, the reason why particularly health and homelessness need to work together is that they're fundamentally intertwined. So unaddressed ill health can be a contributory factor to homelessness, and homelessness can then cause or exacerbate existing health problems. So research that St Mungo's published last year in 2020 showed that people who sleep rough for longer are more likely to have drug and alcohol problems, and those who already had drug and alcohol problems are more likely to have them exacerbated from sleeping rough. People who are homeless are also at much greater risk of mental and physical health problems than the general population, and the experiences that they have from sleeping rough often make it more difficult to access the healthcare that they need. So we had looked at CRISP data, which is an in-depth health assessment of clients who were in hotels across London, and was led by the UCLH Find and Treat team, which found that 6% of people who were accommodated in July to October had extreme clinical vulnerability, and that's nearly double that of the general population. Addressing health and homelessness separately, as if they don't affect one another, has far worse outcomes for the individual and really hinders their recovery from both ill health and from their homelessness. Next slide, please. So the driving force behind Everyone In was to protect a highly vulnerable group from the risk of COVID infection. The preservation of life approach that was taken meant that during the first wave of the pandemic, figures show that crucially 266 deaths were prevented. And as we can see from international comparators in the table at the bottom, the approach in the UK in relation to those sleeping rough was successful in protecting many from COVID. Next slide, please. So I think it was treating rough sleeping as a public health issue rather than just a housing issue prompted far higher engagement with the health sector than had previously been seen. And there was unprecedented collaboration between the local authority and between housing colleagues, where health and housing options were really identified in real time. Services also found that the sort of clinical cohorting of clients by their health status shone a better light on the most clinically vulnerable. And on-site health assessments that were taken in allowed for a better understanding of treatment of clients and their needs. Having this cohort of people inside accommodation as well allowed the health services to work with them closely and in a sort of more sustained manner, sometimes for the first time ever. And the in-reach of the health services also built relationships between the health and homelessness agencies as well as between health and the individuals. So research that Mungo's did previously found that more of a third of those assessed in emergency hotel accommodation in London said that their physical health had improved since moving into a hotel. The reasons why this is seem pretty self-evident, that housing really helps your health, but sleeping rough, you have a poor diet, it's hard to sleep, it's hard to dress wounds, but crucially having their basic needs addressed and having somewhere safe and secure to stay meant there was less focus on just surviving. So you had the headspace to address other needs like mental ill health and drug and alcohol problems or longer term health problems. And it's just generally better for well-being as well. I think the preservation of life approach that we saw over Everyone In also prompted an increase in innovation and creativity. So we heard great examples of key services being delivered on site or easily reached. We saw swift and accessible assessment processes, and there was also easier and more flexible access to drug treatment prescriptions as well. Next slide, please. There were, of course, problems with the response. So there were many services that moved online and were inaccessible for clients who experienced digital exclusion or didn't even just have access to the technology, didn't have a phone, didn't have a computer. And there was a real burden placed on a lot of outreach workers to deliver this sort. So I think from research that we did with clients, a lot of them said that they really struggled with accessing mental health services, largely because these services, are set up for being quite face-to-face, and lots of our clients found it more difficult to have them virtually, although others did say that they actually preferred the service being online because it meant that they didn't feel the stigma of going in, and they found that it was more flexible being able to just call up. So the response showed that flexible working, particularly with the health sector, is able to effectively meet the needs of people sleeping rough. But this didn't happen due to systematic changes. It was a product of the public health emergency. So that's what this commission is aiming to do, is that we make sure that those partnerships that were established during the emergency response are really embedded into future funding settlements and models, so that they become longer term and we can continue the principles of Everyone In. An ongoing problem as well that we've seen is the lower uptake in vaccines amongst people sleeping rough. So I think homelessness providers told the Commission that reasons that a lot of people gave for not wanting the vaccine include sort of fear of side effects, only wanting one of them, not wanting to share personal data, but crucially a distrust of government and healthcare and institutions. And that's something that I think will be really interesting to try and challenge going forward, and how to address that lack of trust and engagement. So we really want to, next slide, please. We really want to see rough sleeping continue to be treated as a public health priority. So that means maintaining the investment in rough sleeping that was seen during the pandemic, but crucially have it more joined up with fewer pots, which are more long-term and more flexible for them, people to decide how they want to use them. This partnership working also needs to continue. So this should happen at a governmental level. So there's a new interministerial group on rough sleeping that's been set up, and that should be used to develop a really cross-government strategy with investment from health, and not just put, MHCLG sitting around the table, but also there's Ministry of Justice that needs to be involved, Department of Health and Social Care. Everyone needs to be around the table and thinking of it as a real investment from their side as well. And then on a sort of more local level, there needs to be jointly commissioned services where health acts as a partner in service provision. We also need to look at prevention further upstream, which can prevent people from getting to the point where their health and their housing are suffering. And so looking particularly at welfare and affordable housing. So maintaining the £20 universal credit uplift, for instance, and building more social housing. And that comes into the second point on building more long-term accommodation. As I mentioned, social housing is really one of the key sustainable routes out of homelessness, and gives people that long-term way to improve their headspace and address health needs that they were going to have. There also needs to be tailored provision for people who have distinct experiences of homelessness. So single white men are generally the most common group found to be rough sleeping, and homelessness support is generally geared to meet their needs because they're the most overrepresented. But many different groups have distinct experiences of homelessness and need different support. So women, for instance, who've experienced domestic abuse and a distinct type of trauma, their health needs are different. So they need different assistance with perhaps pregnancy and childcare decisions, for instance, and need to have a different sort of in-reach from health services. We also need to make sure that people who are homeless are included in the new health landscape priorities. So ICSs, for instance, should have a dedicated focus on tackling healthcare inequalities for people who are experiencing homelessness and rough sleeping. And lastly, NHS organisations should work with local authorities and homelessness organisations to develop and implement effective delivery plans to make sure that people who are homeless are able to access the COVID-19 vaccine, but also other vaccines like flu, which has a huge impact on this population as well. So thank you very much for listening, and I'm going to be passing over to Charlie Norman, who is CEO of MSV Housing.
Thank you so much, Emma, and thanks for those presentations. I was sitting here and thinking that resonates so much with, I'm sure, what all of us are thinking and everybody that has joined today. So thank you very much for asking me. I'm Chief Executive of MSV. We're about a 10,000 home organisation based in the Northwest. And I'm really proud to say that through thick and thin, we've stuck with practically every range of specialist and supported and age-friendly accommodation. And I think some of my colleagues have participated today as well. So I think it's just so important, and I think it's great that the Fed are doing the Starts at Home campaign again this September. I think probably like all of you, my general philosophy and the reason that I work in social housing is because health does begin at home, and health should stay at home and within the community. So it's so fundamental. Started with Nye Bevan when Nye Bevan was the Health and Housing Minister, and it's that Maslow's hierarchy thing about having a really good shelter, a safe and decent home is so fundamental and key to your life and your outcomes in life. If anybody wants some really good bedtime reading, there's a really good book by Lord Nigel Crisp. Some of you may have come across it. And it's called Health is Made at Home, Hospitals are for Repairs. And that's exactly what we're talking about today. And 90% of the determinants of a person's health are about their home environment and what they do in society, not in clinical settings. So for me, the case is made about supported housing as a critical part of that, but I'm actually here to talk about the work in Greater Manchester, because with my other hat on, I chair for my sins the Greater Manchester Health and Housing Group. Have been doing that for several years, and I try my very best to sort of bridge the link between health and housing, and that is going really well, so I'll go on to that. There's two commissions that have taken place. I don't know if people have come across them. They are very much Greater Manchester and North West based, that were launched last month. One's the Greater Manchester Independent Inequalities Commission, and that's taken us to a series of recommendations based on a good life for everybody in Greater Manchester. And also Sir Michael Marmot, who most of you will know, has set a series of recommendations from a commission that he's done about how the pandemic has impacted on people. You know, we had 10 years of austerity prior to the pandemic, housing crisis, climate emergency, lots of poverty, lots of health inequalities and inequalities generally. And that report very much brings that to life, sadly. As COVID-19 collided with all of those things, unfortunately, it also had the impact in the Northwest of further reducing life expectancy in 2020 more than anywhere else in England. For those of you that do work in the Northwest, I'd recommend that you read the report and the series of recommendations in it. And also, if you lived in Greater Manchester, you were 25% more likely to have died from COVID than any other area of England, which is really, that sort of put fire in my belly when I heard it and thought, we've been doing some great work, but we've got to do more. So all very depressing, but we've got a once in a lifetime opportunity to respond, to use Starts at Home, to respond to those commissions, things like the Kerslake Commission as well, and really sort of get over ourselves and work together across all parts of the system for the greater good. So luckily in Greater Manchester, we have been moving and learning together for some time. And we've got a tripartite agreement between the 27 housing providers, the combined authority with the 10 districts, and also the Greater Manchester Health and Social Care Partnership. It's the first of its kind in the country, and it was launched earlier this year, but was built on years of working with health and social care, which has been fantastic. And the overall emphasis of that is to relieve pressures on the health and social care system. We know that cold homes, for example, cost the NHS £1.4 billion a year. But for me, it's about relieving pressure on the public purse, but it's more about individuals and their outcomes and the lives of individuals and life opportunities. So the Greater Manchester Housing Providers, there's 27 organisations, some people might be representing those in the seminar, the webinar. 250,000 homes between us. We employ 28,000 people, and in the last few years built 40% of all new homes across Greater Manchester. We work together on many priorities, so very much on homelessness. We work together on Everyone In. We've got a social impact bond, a bed every night, lots of work on homelessness and trench rough sleeping, but also families stuck in temporary accommodation. So just in Manchester alone, there are 2,300 families stuck in temporary accommodation, which is awful. And we're also working together on net zero carbon targets. We've got a target for 2038 in Greater Manchester on ageing well and starting well, living well and ageing well across the spectrum, and building 30 to 50,000 new homes, including social homes. I couldn't agree more that we need much more of them, including supported housing homes. I think everything we do is about health creation. Everything's about health that we do. The Healthy Homes group that I chair, we've had lots of joint projects around delayed transfers of care, hospital discharge projects, housing options for older people, social prescribing, lots of work that's sort of built with one or two organisations individually running fantastic projects. It might be about mental health key workers shared across 3 organisations, which we do. And then that's scaled up and we work together to sort of replicate that. And we've been working on mental health in particular in the last few months, and we'll be doing so in the next 12 months because the evidence is clear that people's mental health has been so badly impacted by everything that went before and then the pandemic. And a set of pledges for care leavers and helping care experienced young people to move into settled accommodation. And I was dead excited a couple of weeks ago because I went to our converted office, which has now been converted into 17 flats for care leavers who will have a place to call home for the first time, which will be brilliant to see them all move in. And just around the corner from that, an extra care scheme, which was built and handed over during the pandemic, which is really difficult, but my colleagues did an amazing job of that. But we've got a particular piece of work on supported housing. I just want to finalise about that. I think just in the last couple of weeks, we had lots of discussions around the importance of supported and specialist accommodation in dealing with the homelessness situation and also recovery from pandemic. So some of the things that we've been doing to work together are around busting barriers, because as we all know, there are lots of barriers to the provision of, the retention of this very precious asset that we have, and also what we need going forward. So we've been working collectively for some time to build a census and a baseline data as to what we actually do have across Greater Manchester, and I don't know if other areas have done that. We now know we've got 33,000 units of, I don't like the word units, but homes that are supported. And also we've done some predictive modelling and work with Housing Lynn to look at what's needed going forward. So as an example, we know we need 1,457 learning disability homes by 2031. We know what we need for extra care, mental health, wheelchair access, those kind of things. So importantly, we're also looking at the sort of reuse and repurposing of existing decommissioned services. And also trying to support our local authority partners with supported housing strategies across the 10 districts. We need more sort of happy living so that people can right size into the right accommodation for the time of life. That will help to address the housing crisis. We need more extra care. We need more learning disability schemes, all of those things. But what we will need to support that is higher grant rates from Homes England. So having discussions with Homes England. Typically you get about £20,000-30,000 for it's going to have to be in the region of £70,000 to £75,000. Best use of land and not best value for land, but what are the best options for and outcomes for the individuals. Better planning and more flexibility, and then the really critical issue about commissioning and longer term commissioning arrangements with your local authority partners. So we've had some really positive discussions with directors of adult social care and children's services about longer term commissioning and models for support, and being flexible about that and working together on it and having some certainty. So the other thing I would say is that we're looking at lobbying, and I'm old enough to remember supporting people, some of you probably aren't, but when supporting people was lifted and the ring fence around that created a reliance on intensive housing management and instability in terms of the revenue funding for this type of housing. So we're doing some collective lobbying about putting some kind of ring fence around that going forward. And as RPs, we are trusted, we're ethical, we're not for profit. We've got a track record and we provide really good quality, affordable, supported and specialist housing. So the case is made. For example, we know that a care leaver scheme that we're just developing for 16 to 18-year-olds will save what's currently costing £4,000 a week for a private care contract to £500 a week. And we know there'll be better outcomes than that as well. And with the extra care scheme, we know that as less formal care is needed when people move into extra care, less hospital admissions, reliance on GPs, living longer and happier and healthier, and costs are reduced to the system by 16%. But Lord Best has been talking recently about the fact that when he was involved with the NatFed, I think the sector had 40% of older persons accommodation, and currently it's 7%, and we need to get back on track with that because we've got an ageing population and a crisis there as well. But more importantly, this is all about people, and it's about people having the best possible outcomes in life, from having a really safe and comfortable and warm home to live in, and having the right place for the right time of their lives that's affordable and that's respectful, and having safe and healthy, fulfilled lives. So I think it's got to be person-centric, but I think we've got to continue to campaign about the importance of supported and specialist accommodation. And I can think, and you can probably all think of a number, like hundreds and thousands of people whose lives have really sort of gone on to be very successful because they've had that start. So I'm really happy to be here and take any questions, and it's a pleasure to be here. Thanks.
Great, thank you very much to all our speakers. There's some really good examples in there and also great recommendations that we'll definitely be continuing to promote. We've got quite a few questions, so thank you to participants for sending those in. I will start asking them. I might ask some questions to all panelists and some are for specific panelists. So let's get started. Okay, Angelina, we've got a question here from Altaf Khan at In Communities. He wants to know what types of accommodation you provide.
In terms of property, or you mean the services? I'm not really. I mean, the services that we provide are largely from properties that we own. The types of properties that we own are obviously very different in their makeup, and we generally, the number of properties within flats or properties or rooms within an accommodation range from, I would say, anywhere from sort of 5 or 6 up to potentially around 25. We generally steer away from larger properties than that, because we want to kind of move away from an institutional feel. In terms of the type of tenure, we obviously aim to provide the people that live in our services with the most secure type of tenure possible. So the majority of the people that live in our services are on assured short hold tenancies. There are some services such as the forensic mental health service where the agreement was at the very beginning when we were implementing that service that the people that would live in that service would be issued license agreements. But licenses aren't something that we generally use a lot of in our services. They're generally assured short hold tenancies. And of course, we do also invest in our property. So we will reconfigure properties according to specification. So if there's a specialist specification, for example, rehabilitation, one of our rehabilitation services in Tower Hamlets, we invested and reconfigured that property with oversight from the Health Trust, specifically for that cohort and client group. And again, we did the same thing with the forensic mental health service. We invested quite significantly in that property to ensure that it was appropriate to meet the needs of the people that would be using the service being run from it. So I hope that's answered the question, and I'm sorry if it hasn't really, but yeah.
Okay, thanks very much. I've got another question, which I think will be for you, Angelina, and Charlie as well, around how you've managed to overcome the challenges of information sharing. And I think this is between housing staff and health and vice versa, potentially GDPR as well. So shall we start with you again, Angelina?
Yeah, sure. I mean, generally speaking, the way that we partner with our landlords, we're not necessarily sharing confidential information about the clients and their backgrounds. We generally have ICAs in place with health trusts that we communicate with. And obviously, if there's anything personal, for example, commissioning authorities. So ICAs are always put in place to cover that off. We also share databases with some of our health trusts in areas in which we operate. And you're living, you're working, you're operating in real time in that sense, because you're sharing so much information onto one database. With housing, it's a little bit different for us, because we don't generally need to share information that is confidential to the background of that individual living in the property. And if we do have arrangements in place like that, then we would have ICAs in place to enable us to be able to share that type of information.
Thank you. Charlie, have you got anything to add from the Greater Manchester perspective?
Thank you. I froze a bit then. Can you hear me? Yeah.
Yes, we can.
Similar picture in terms of individual cases and sharing of information. I mean, it's very difficult, isn't it? It's a perennial issue between providers. One of a couple of examples that I can think of where that's working well is we've got a place-based working approach across Greater Manchester, and in Manchester in particular, building on the work of working with health and social care and local partners. We have local care organisation approaches where you've got a range of people from different organisations and parts of the system coming together to collaborate on individual complex cases and issues within localities. That's based on localities of about 30 to 50,000. So that's working really well. And that's obviously there are information sharing protocol agreements in place for that. In terms of the wider sharing of information, we tend to rely on the fact that we've got this tripartite agreement between the three parts of the system. Contractual, potentially commercially sensitive information, all of those kind of commissioning information, that kind of thing. The workaround is the formal tripartite agreement that we have in place. So that has been enormously helpful. So having those kind of formal structures and partnerships in place can often remove barriers that you sometimes have to navigate through, don't you? So, but it is difficult, but I think you've got to find ways around it through local information sharing where it comes to individual cases, and then have that broader strategic picture for working in partnership.
Thank you. And Emma, actually, sorry, were there any kind of issues with information sharing in the hotels? You mentioned that St Mungo's worked in hotels and there were services on site. Did anything come out of that?
Yeah, I think it was, so we're going to be looking at that a bit more in the final report, and I think on information and data sharing is going to be a section in the final report as a way to embed integrated working, because it is obviously one of the main sort of stumbling blocks that that people have. I know that, for instance, with health teams coming in, it was very, like, we had to make sure that there were specific data sharing agreements in place. And I think over everyone in, what we heard from other providers as well was that there was a slightly different approach to, well, at least to risk, and therefore people would sort of push through things quicker is probably the wrong way to put it, but it was a priority to make sure that health and homelessness were working together, and therefore had the arrangements in place as quickly as possible. But it's definitely going to be one of the focuses of the final report.
Thank you, Emma. And I've got a question here about the Kerslake Commission. Could you tell us some more about the makeup of the commission and kind of where the learning is coming from, whether it's just St Mungo's work or if there are other sources of information?
No, so you'll be pleased to know it's not just St Mungo's. So we're the Secretariat. So we sent out a call for evidence, I think it was back in May, and had over 100 submissions. I think about 15 of them were from health organisations specifically, which was really great to see. And then we take all of the submissions and really try to form a picture based on all of those submissions, and we follow that up with consultations with different organisations, local government, health, homelessness. We're trying to get a really broad picture from across the board, and we've got an advisory board as well. And I really should know how many people are on it, but it's about 13 or 14 people that are on the advisory board that help to inform the findings of the report too.
Great, thank you. And you said the final report's coming out in September 23rd, am I right?
Yeah.
Yeah, great. I've got another question. I think it's for you, Emma, but I imagine the rest of the panel can also chip in on whether you have data around how many rough sleepers have secured permanent homes following the kind of action during the pandemic in the areas that you cover. So I imagine St Mungo's has figures, but perhaps there are figures for Greater Manchester, and maybe Angelina, look ahead to have some. If you don't, that's fine, but any figures you have, that would be helpful. Thanks. Shall we start with Emma?
Yeah, so we have figures specifically just for St Mungo's clients that we've helped move on. I don't have I think it's around 6,000. I don't have the figure to hand, so I'll just double check and I can put it in the chat.
Thanks to
Yeah.
Charlie or Angelina, did you have any?
From my perspective, I wouldn't be able to sort of pluck that figure out of the air at the moment, I'm afraid. But we can, I can certainly get back to you if there's follow-up questions after this session.
And I can do the same thing, but what I would say is that there are structured projects in place in Greater Manchester, such as the Housing First project, and there are figures coming through monthly on how many people have been moved from the streets to their own settled accommodation from that, so I can share that, and also a bed every night, and other projects that people are working on. So yeah, I can certainly share that. Thank you.
That's helpful. Thanks, everyone. We've got a question that's getting quite a bit of interest as well from the rest of the audience, from Peter Webb. It says, new supported housing schemes are seen as too risky for a lot of RPs. So how does the panel see those risks being mitigated, and what role can RPs play in that? Who wants to go first?
I can do that.
Charlie, go ahead.
It's just because it's so fresh in my mind, this, and I'm so determined that we overcome these barriers. And I think I tried to touch on this in my thoughts before. It is really difficult, and boards are extremely nervous. My board it gets nervous. We had so many conversations about the extra care scheme that we delivered, but then when I visited that scheme and saw the people who've moved in, had a chat with them, it just makes it worthwhile that you've sort of pressed on with the shenanigans that you have with going through governance and trying to get the right money in place and the right support in place. But I think the work that we're doing in Greater Manchester is very much, it's moved to this. So the maturity of the partnership, and because we've been working together as a coalition of the willing for so long, and there's absolute recognition that there is the importance of supported and specialty accommodation. If we're going to crack homelessness and rough sleeping issues, if we're going to move people through to the right accommodation for the right time of their lives. So what we've moved to now is actually what can we do to remove those barriers, and we do all know what the barriers are. It's revenue funding for commissioned services. So, and that's at the behest of local authority budgets, which might be cut because of settlements with government and pressures on local authority budgets. It's grant rates with Homes England. There's 10% of the Affordable Homes Programme given for this area, and I think it's going to be quite difficult for Homes England to actually get that money out the door unless it's with higher grant rates and with conditions around ring fencing, revenue support funding, similar to the NSAP programme. So I do think we need longer term commissioning. So I'm talking 5-10 years for the revenue funding, the wraparound support for people. Moving from sort of 30 grand to 70 odd grand to recognise the complexity and the bespoke nature of the schemes with Homes England grants. I think sometimes if you've got a good local authority supported housing strategy and you're helping that local authority to discharge a need for learning disability or women's refugees or extra care or whatever it may be, then it may be that there will be some funding, gap funding as well with that local authority. We've certainly experienced that with Manchester, which has been fantastic. And I just think the things around land and supply. So, for example, we've got one public estate. I think disused hospital sites and other sites that are in public ownership should be going for less money to organisations, ethical organisations like the housing providers or groups of housing providers to develop on that land for better outcomes for individuals rather than top dollar and best value for the actual land. And I do understand where that comes from, but it's about discharging duties and having best outcomes for individuals. Flexibility around planning, getting political buy-in. Sometimes there can be political issues. So I think it's all that stuff around capital funding, revenue funding and commitment, and ultimately it's about partnership. So we spend an inordinate amount of time just talking to each other and talking about the importance of this and gaining understanding and working with directors of adult social care and with health and social care. And I think all the departments need to talk to, I think Emma mentioned it, Treasury, MHCLG, Department of Health all need to recognise the value, don't they, and the savings that can be made in the long term and sort of remove those barriers and that silo thinking. And it's all got to be done in partnership because not one of us can do it on our own. But I agree, Peter, it is really, really tricky and risky. And that's why we've moved on to this thing around trying to de-risk it and remove the barriers and get something a bit more secure in place so that boards can be more comfortable with that decision making. It's really tough.
Thanks, Charlie. Our other panelists, would you like to add anything?
No, I think Charlie put it really well, actually. I don't think I have anything else to add to that. I mean, I would like to see, as Charlie said, more capital funding so that there's more supported housing development. And also, we need to make sure that housing associations are brought in more to the discussions around, health, social care and housing. I mean, the three are the cornerstones really to supporting those most vulnerable in our communities. And then, of course, there's the other side, which is the kind of revenue income side. And there does need to be more security there, I think, for providers, stroke housing associations with longer term contracts in place. And, whilst there is, I think, under the new ICSs, there will be new opportunities that come with that, possibly for negotiation on the length of contracts and things. I'm hoping that will be the case, that will change in terms of the conditions in terms of contracts, because we need it to really, the cycles, the 2 and 3 year cycles don't offer any form of security. And there certainly isn't, it doesn't make sense in terms of development, even refurbishment and investing in property significantly. If you've got a 2-year contract, that's kind of, you're never going to be able to kind of make ends meet on that. So yeah, I'll leave that there.
Yeah, I don't think I have anything to add really to Angelina and Charlie, just backing up the points that they've made. And I know that sort of the joining up the capital and the revenue funding was one of the recommendations that we made in the interim report, and looking at that longer term commissioning cycles as well.
Thank you. Thanks all. We've got another question, which is kind of potentially a follow-up question to that, and a bit philosophical in a way, from Angela Gascoigne at Shell. So there have been a lot of comments on the system that we work in. So Angela wonders whether the panelists feel that they're changing the system rather than, if you like, overriding the system. And if the system is being changed, what is it that's driving the change? Go ahead, Charlie.
Thank you. Well, I think I tried to mention again that what we've tried to do in Greater Manchester is work together at scale for a purpose, because we all want the same thing, which is better outcomes for the residents of Greater Manchester. And what I would say is that that's taken a lot of time. It takes time to build relationships and to understand each other. I mean, health has got a whole different language, hasn't it? So, I think because we've been in an area with devolution and with a Metro Mayor, that's been a really important factor. So I think political support and buy-in and the leadership of strong mayors like Andy Burnham have been really, really pivotal to the success of that partnership. And then I think because the 27 housing providers have coalesced around the same things and aligned our priorities with health and social care and the combined authority in the 10 districts, there's just a common understanding and a common purpose and goal, and that's a really good starting point, isn't it? So and there's a lot of bureaucracy and hierarchy and structure and lots of working groups and different architecture around it, which is quite difficult to navigate through. But there is a sense, I think, and it's only been after about 6 or 7 years of working together that we actually are changing the system. And when we've looked at the ICS approach coming forward in the white paper from the health and social care point of view, you look at the sort of duty to collaborate aspect of that, which is good to see. I feel we've been doing that, for a few years now with Health and Social Care Partnership in GM, which is great. So I think it's just will and determination and all wanting to be on the same page and achieve the same things. But you have to go through a process of understanding and building relationships, in my view.
Yeah, I'd agree with that, Charlie. And also, I do think it's changing the system, but I do think that change, it's a process, isn't it? Like you said, and I think it takes time for that change to kind of evolve over a period of time. Certainly, what I'm seeing is from where we are is, in terms of that collaboration and working under ICSs, in a sense, you're already in them. You're already working as a partner in those ICSs. But what I am seeing is that there is a difference and a slight change and a move in terms of how services are being funded. So there's lots more organic growth coming through as part of those partnerships and collaborations. We're not just kind of on the kind of traditional procurement path that we once were. We're seeing, contracts and discussions. Contracts emerge out of discussions, basically, and direct approaches. And so that kind of relational partnership is really important, fostering those partnerships and relationships moving forward, and not just between sort of providers, housing, health, but also, providers with providers working together. All of that stuff I think we're going to start to see more of. So the system, I think, is changing. I think it will be slow, but we're certainly seeing, I think, a difference in the way that we're working together.
Yeah, I think I'd really echo what Charlie and Angelina were saying. I feel like over the pandemic as well, it's been a real push to realise actually what has been working and what hasn't been working in the system, and what people can do to change it, and sort of making sure that we gather all those lessons together is a really good way to show what the system changes are needed, because before that it can just be, tweaks here and there. If you've got an entirely new way of working that saw good outcomes for the people that we're trying to help, you can use that to show actually we need to completely, overhaul some of the ways that we've been working previously. And I think some of the ways you do that is through bringing together those examples of good practice, like Charlie was talking about in Manchester, and saying, okay, well, here's somewhere that's, it's doing really well. Let's try and implement that across the rest of the country. We've got examples of where the system works better. Let's try and find out why the system isn't working in your area and apply, these examples where it really is working well. So I think that's one of the things you can do, is just bring together the right people who can share what they're doing. So here is an example, and just say, okay, use that learning and try and embed it where you are.
Okay, that's brilliant. Thank you very much. Thanks to all of our speakers, and thank you to everyone who has tuned in to listen to the webinar. As I said, the recording will be available next week, and we've got some links in the chat to the reports that were mentioned, but we can also send those links around. We've got a quick poll that's going to come up just at the end to ask for your feedback on this session. But thanks for joining us, and hope to see you at future NHF webinars. Thanks, everyone.